Right, so now we've looked over the etiology, let's have a look into the diagnostic imaging as well. Imaging is invariably indicated. CT or MRI of the brain, skull base, and mandibular division of the trigeminal nerve, or CT scanning may be appropriate. If imaging fails, lumbar puncture to exclude carcinomatous meningitis or leptomeningeal metastases may be necessary. Blood tests may be needed to exclude connective tissue disease or other causes. So complementary studies are needed to establish the etiological diagnosis with laboratory tests to discard the possible causes underlying the trigeminal neuropathy and the opportune radiographic examinations. So this must be done in the form of plain X-rays or a routine cranial computed tomography scan, a CT scan, in order to discard alterations of the maxillary sinus, of Meckel's cavum, which is a dura mater pouch containing cerebrospinal fluid, or the pontocerebellar angle. Radiological evaluation in patients with trigeminal neuropathy, including CT and MRI imaging, to analyze the proximal region, including the brainstem, preganglionic region, gaseous ganglion, and cavernous sinus, and distal zone, which includes the extracranial portion of the three roots, and the trajectories of the fifth cranial nerve. So usually the difficulty of identifying the location of the trigeminal nerve injury based on the clinical manifestations is something that's often stressed upon. Now, because neurosensory function cannot be assessed directly, indirect clinical measures of sensation, including temperature discernment, vibration, pinprick, light touch, and two-point discrimination, are evaluated for representation of neurosensory function. There have been variable methods of determining these measures. An MRC scale has been developed by the Medical Research Council. A modified MRC scale, originally developed for the upper extremities to grade and monitor brachial plexus injuries, has been adapted to assess the functional sensory recovery of trigeminal nerve injuries and make comparisons between studies if possible. The MRC scale provides a global assessment of neurosensory function by using a combination of measures. The scale ranges from a score of S0, which is no improvement, to S4, which is complete recovery. For peripheral nerve injuries, a score of S3 or higher has been defined as useful sensory function, USF. The advantages of this scoring system are that they may provide an objective criteria for classification of results. They will promote and develop common and accepted use of the scale in all disciplines in which peripheral nerve surgery is performed. Now that can be in hand surgery, plastic surgery, reconstructive surgery, neurosurgery, and even oral and maxillofacial surgery. They can enable a comparison of data in various studies in the literature, even when the scale was not used originally by the study authors. Now, documentation and mapping of the involved cranial nerve dermatomes on the patient's face and clinical photographs are helpful for monitoring and demonstrating changes over time in that affected area. So guys, that was just a little bit about the etiology of trigeminal sensory loss and some of the diagnostic tools we use to pick up on it. So if you want to learn more things every day and stuff about your favorite topics tailored to your medical degree, then stay tuned to sqadia.com.